We're here to discuss the groundbreaking trials here at ESC 2019 in Paris. On my right is AHA President Bob Harrington, and I'm pleased to welcome AHA's President-elect Mitch Elkind. And so we're going to really begin by talking about an interesting trial, Afire. Bob, why not start?
Yeah, in the spirit, Ivor, of what we've been doing the last couple of days of trying to talk about trials that might have some immediate applicability.
Yep.
I think we've chosen some good ones today.
Yep.
Afire fits into that category. Afire was a study that looked at what I would say is a very common combination. People with atrial fibrillation and coronary disease. In this case, stable coronary disease.
Stable disease.
Trial done in Japan, which is terrific to see a trial coming out of Japan presented at ESC. And it was really designed to try to ask the question, what's the best antithrombotic regimen long term in a group of patients with both stable CAD and atrial fibrillation? And it was trying to get at the issue of, can you get the stroke prevention protection while also getting the ischemic protection? So, you know, we've gone through all of these things as a double therapy, as a triple therapy. And I think the world has really gotten to, it's mostly dual therapy. It's an anticoagulant plus an antiplatelet agent. Can we just go to one? So it's an interesting question.
And so, Mitch, you know, we're extremely fortunate, you know, Bob being an interventional cardiologist and you're a stroke neurologist.
That's true.
What an amazing compliment for us to be talking about Afire. Your perspectives.
Well, I would guess that we probably have different takes on this too, because Bob was probably in the camp where people would expect to give an antiplatelet on top of the anticoagulant to get the, you know, protection against stroke as well as protection against coronary events. And from my point of view as a stroke neurologist, you know, it's all about anticoagulation, and we like to try to avoid patients being on an antiplatelet as well, especially because our patients, the stroke patients, are older. They're at higher risk of having hemorrhagic complications, hemorrhagic stroke in particular. And so I was excited to see that the results of this study suggest that there's no added benefit to being on an antiplatelet on top of an anticoagulant. I actually think that fits with a lot of the earlier data suggesting that anticoagulants have a benefit against coronary disease also, although a lot of that data wasn't really accepted by a lot of people perhaps.
Yeah, I mean, I think you bring up a really interesting point that the cardiologists, particularly interventional cardiologists, we've always been the fan of, you have to have the antiplatelet agent on there.
Exactly.
What was neat about this study is that they didn't take people in the peri-stent period, they took them out after a year. So then, as I think you rightly point out, Mitch, there's all the older data, a lot of it with warfarin. The anticoagulation might actually be quite good. But I think the cardiologists are getting excited again about anticoagulation, not just for stroke and AF, but for vascular disease after COMPASS last year. So we're starting to really see what is the optimal therapy. And one of the things that I'm fascinated by is that we have all these drugs available now, aspirin, ADP inhibitors, anticoagulants, novel anticoagulants. What's the optimal combination? This one starts to get at, and like you said, this trial really was pretty successful. DSMB stopped it early.
Right. And keeping in mind, again, it's the patient population.
Yes.
Stable coronary disease, which atrial fibrillation, where obviously you've got these implications.
Yeah, I mean, and you mentioned that this study was done only in Japan. I'm just curious whether either of you think that there's any implications of that for what we do in the United States. Do you think the results are generalizable to other countries as well? Is there any reason to think otherwise?
You know, it's interesting. When we do trials in the United States and largely Europe, we say, well, of course they're generalizable. And I think we need to say the same thing when we do a trial in Japan. I think the key thing that I look for is that were people treated the same as they are in our practice environment, and they look to be. And were there any metabolism issues with these drugs that we should be thinking of? And I'm not aware of that. And so I'd say that if you have a patient with stable coronary disease and AF after a year out from stenting, the rivaroxaban alone anticoagulant looked pretty good. And maybe not just pretty good, low the risk of mortality.
But Mitch, I think you do bring up an important point, recognizing that coronary artery disease actually is applicable to all racial net groups around the world.
Right.
And so we always have to keep in mind that there are many factors that influence coronary artery disease, including one's gene pool. So perhaps, validation cohorts through registries might actually be able to provide that kind of validation of these trial results.
And always nice. I mean, I'm a big believer that you'd like to have trials that represent the globe in terms of their racial and ethnic diversity makeup. And in terms of the practice styles. I mean, I think when we look at Japan from a practice style and you look at the concomitant medicines, it looks pretty much like what we do.
Yeah.
And I think that's important.
Right, and perhaps also the fact that they did use a novel
Yes.
or a direct-acting oral anticoagulant, which may have, changed the equation a little bit in terms of which anticoagulant was being used. That might make it an even more attractive option then.
Great. Exciting. So let's move on next to something that's also a global problem, that is hypertension and its management.
Sure.
And Hope 4, I think, had a number of interesting hypotheses and results. So Mitch, why not tackle Hope 4?
Sure, thanks, Ivor. I think Hope 4 is a very exciting trial. I mean, basically, what it tells us is that using non-physician healthcare providers or healthcare workers, one can really have a big impact on cardiovascular risk factors, not only hypertension, but also lipid control, and that this can be done in resource-limited settings. The trial was conducted in Colombia and in Malaysia, and they found big effects, and this has real implications, I think, for what we can do for global health.
Absolutely. The cluster randomized control trial was quite interesting. Your thoughts about that?
Yeah, I mean, I think that they really went after an efficient design for the areas that they were in. They had roughly 30 or so communities that they had the patients segmented into, and they randomized by the cluster, which is a very good way of doing it, particularly if you're going to do a lot of intervention using things like community health workers, which is a lot harder to think about on an individual patient basis versus a cluster. So a very efficient trial design. The use of community health workers and engagement of families and engagement of the primary care providers all, I would say, don't just apply to the research-constrained system, but apply to our own.
Absolutely.
And this is a time where I think a trial done at the global level could also be brought back, because we certainly have many of the communities that we either all live in or surround us where we could really benefit from this type of intervention. As the Heart Association, as you both know well, we're now really advocating for things like community health workers and really getting all medical professionals to work up to the scope of licensure so that we can offer team-based care in the most cost-effective way.
I think this is an absolutely important point, and as you know, we are thinking about the social determinants of health through a health equity lens.
That's right.
And what a better way for us to really not only be able to leverage first, world-class medicines, but really engaging non-physician health providers and community health workers in that space.
Absolutely, yeah. What it reminds me of a little bit are the studies that looked at barbershops or beauty salons as a way to detect patients with high blood pressure. In this trial, in Hope 4, the community workers were really used to try to detect these elevations in blood pressure, and then they were able to continue treating people under the supervision of a physician. So it's not that there's no physician involved, but the people on the front lines were the community providers. And I couldn't agree with you more, Bob, that we think about global health, and we often forget that there are tremendous disparities within the United States and many other westernized or advanced countries, and so that's an important thing to remember.
And what I will add is that there are implications for implementation science.
Yes. Yeah, this is a great example. I mean, Mitch said it earlier that this is not a drug study or a device study.
Right.
This is an implementation study. This is trying to understand how do you take what we know and actually get it out there into the community. What we know is that you want to lower lipids, you want to control blood pressure, you want to control cardiovascular risk. And boy, kudos to the Hope 4 investigators and to those communities for teaching us something, which I think will be one of the big stories of ESC.
Absolutely. So, we have already talked about atrial fibrillation in relation to stroke. And obviously, you're now talking about hypertension, which is these are all aspects that have significant burden. Why not let's shift, Bob, and talk about routine coronary revascularization and coronary artery disease, complete.
Yeah, this was the complete study, also actually done by the McMaster Group out of Canada. So this is a study that's trying to go after a question that's really been a vexing one in interventional cardiology. That if you come in with an ST segment elevation MI, and you identify the culprit artery, but they have other disease, do you open just the culprit artery, or do you open everything? And this has been an area where people have gone back and forth on, because data have conflicted.
Right.
Some observational data suggests you should open all of it. Some of the smaller trials suggested no, maybe ought not to do that.
Right.
Stick with just the culprit artery. They did something here that I think was very good. They first off said, okay, get the culprit artery open, identify the others, and they were randomized to complete revascularization or just culprit. But they didn't say you had to do it in the same setting. You had to do it before you went home.
Right.
But you didn't have to do it in the same setting, and that's the area that interventionalists have really debated. If you have a 95% mid LAD, but the culprit was 100% occluded right, do you come back and open the LAD? Do you do it at the same setting? And what they showed is that there was superiority of the complete revascularization and no time dependency. There was no heterogeneity about whether or not you did it the same setting, you did it a little bit later, and that's an important observation clinically. Because that allows you to make all the decisions of, oh, it took me 5 minutes to open this right. Maybe I can just go do the other blood vessel now. They're hemodynamically stable. Everything seems fine. I haven't used a lot of contrast. Versus, oh, this took me an hour to get this blood vessel open. I've used a lot of contrast. Maybe we come back another day, and that's okay.
And that's okay.
That's okay.
That seemed, and from a cost utilization standpoint?
It looks as though it prevents a lot of repeat procedures having to come in. And so we haven't seen the cost effectiveness analysis yet.
Right. Okay.
But I suspect as they do it, they prevented some pretty serious events, including rehospitalizations and including ischemia-driven revascularizations. So I'm going to say that we'll have to see the cost effectiveness analysis, but I would estimate that it probably is at least favorable to neutral.
Right. All right. So interesting.
Wait to see it.
Interesting hypothesis, and it's probably worth. I mean, and Mitch, you can comment as well. That perhaps as trials, because I remember the O trial.
Yes.
Which actually I'm going to be able to remind our listeners as to what that is. I'm really curious whether you think as we continue to do a better job at just managing coronary artery disease, whether the biology and the phenotype of our patients are actually changing over time.
Oh, I think that's true. And remember, just so that the audience remembers, that the occluded artery trial, run by Judy Hockman, an HLBI-supported study, was really looking at that question. You've had your infarct, your artery's closed, do you open it in a delayed fashion? And the answer was no.
Right.
You leave it closed.
Right.
Without ongoing ischemia, etc. Now, what you're setting us up for perfectly is a trial that we've been involved with, also sponsored by NHLBI, also led by Judy Hockman and David Marin, the ischemia trial, which we presented at Sessions.
That's right.
Because that's asking the question, if you've got ischemia, demonstrated by stress testing with or without imaging, and you get randomized to cath lab and revascularization or medical therapy, is medical therapy enough? Or do you benefit from medical therapy plus revasc? Come to Sessions and you'll hear.
And that's going to be fantastic. And Mitch, I'm not going to leave you off the hook. I mean, of course, the brain is also an ischemic bed.
Yes, it is.
And perhaps, more broadly, what do you think are the implications of both lytics as well as interventions in the ischemic world?
Well, we have seen tremendous changes within the world of stroke care in the last 5 years or so. I mean, it's really mirroring the successes that you're reviewing briefly here now in the cardiac world. So we've moved from using lytics acutely up to 3 hours back in '95 to 4.5 hours in the early 2000s to thrombectomy in 2013 up to 6 hours, and within just a few years we've jumped to a 24-hour time window to do thrombectomy. So we're now set up, I think, to start doing these kind of almost implementation trials.
Yeah,
You're not changing the technology at this point in these particular trials you've just discussed. It's about how do you apply it, which patients, how many lesions, how quickly, all these sorts of questions. So I feel like we're a few years behind in the stroke world to what's been done in cardiac care, but we're catching up.
Terrific. So, on behalf of both Bob, Mitch, and myself, please return when we come back to actually have a wrap-up at our next session. Thank you very much.